morning, PPS Lakeshore family. Mohan sir, Lasajandi sir, Mallie Madam, Jaya Madam, all senior consultants, colleagues, friends. So today we will be having the breakfast CME by the Department of Anesthesia. Anesthesia in the new millennium and beyond. We will be having 3 speakers. Dr. Mallie Abraham, Dr. Jaya Susan Jacob, and Dr. Anju Mathew, and the session will be chaired by Mohan Mathew sir. So without wasting time, we'll invite the chairperson and the speakers to come on stage and start the proceedings. Thank you.
Good morning, friends. Although the crowd is small, I'm sure it will build up as the meeting progresses. I'm thankful to Dr. Arun, Dr. Lasajandi, and Dr. Padma Kumar, who have evinced a keen interest to support this department. Thank you for coming early. My colleagues from the Department of Anesthesia are all seated at the back. I'm sure all of them have had busy nights and busy days. We thank you for all your cooperation. And now I continue to go ahead with the meeting. The first speaker is Anesthesia in the new millennium. And she's covering only 20 years of anesthesia. Because if you take the history of anesthesia, it is a long history and we won't be able to do justice in 15 to 20 minutes. So I request Dr. Mallie Abraham to come forward and do a lecture.
Respected seniors and my dear friends, a very good morning to all. Deep down, every surgical patient has the same worry. How safe is anesthesia and surgery? Many times we have seen fear in their eyes before they go to sleep. Anesthesia has come a long way from the time W.T.G. Mohan first demonstrated it in Massachusetts General Hospital on October 16, 1846. He revolutionized the practice of surgical anesthesia. W.T.G. Mohan is considered as the inventor and revealer of inhalation anesthesia, before whom in all time surgery was agony, by whom pain in surgery was averted and annulled, and since whom science has control of pain. This was the epitaph on his tombstone. We admire pioneers and inventors. It's always good to remember our predecessors when we move on to the new millennium. Early anesthetists were concerned with the relief of surgical pain and recovery from the effects of agents used. Most surgeries those days were performed on the body surface. But with the introduction of asepsis, there was a dramatic expansion of scope of surgery, and this necessitated major changes in anesthesia techniques, which led to new discoveries. Now the role of anesthesiologist has evolved from that of a physician, primarily responsible for providing anesthesia and managing the postoperative pain, to that of a perioperative physician, responsible for optimizing patients with the coexisting medical conditions, managing the intraoperative period, and taking care of his postoperative recovery also. By virtue of training and experience, anesthesiologists are perioperative physicians. They encounter patients with several comorbidities, the etiopathogenesis of which they need to master. They also need to master the pharmacodynamics and kinetics of several drugs being used by these patients for their illnesses, and possible interaction of these drugs with the drugs that might be used during the perioperative period. In this era of hectic life, nobody has the time to spare or wait. Everyone wants things to be done fast. The concept of fast-track surgery was introduced to facilitate early discharge from hospital and faster resumption of normal activities after elective surgery. And in this, the decision of the anesthesiologist play a significant role in fast-track surgery through their choice of medications, anesthetic techniques, use of prophylactic drugs to minimize side effects like pain, nausea, vomiting. And the anesthesiologists work closely with surgeons and other allied specialists, forming an important team member in prehabilitation. Rehabilitation is the process of enhancing an individual's functional capacity to enable him or her to withstand a forthcoming stress like surgery. This is basically preoperative optimization. Whenever patients are posted for surgery, numerous questions plague their mind. How safe is anesthesia and surgery? And often patients confide that they are more worried about anesthesia than surgery. But anesthesia is actually a reversible medically induced coma, and it's one of the marvels of modern medicine. Carefully calibrated drugs, ventilators and advanced technology keep patients breathing and comfortable when being operated, blissfully unaware of what happens on the surgical table. And that's also important because awareness during anesthesia is really traumatic, and such patients can have long-term psychological problems. Anesthesia machines are always an integral part of our clinical practice. It was originally designed to deliver oxygen along with anesthetic gases. But the modern anesthesia workstations with integrated monitors not only deliver gases but can monitor the hemodynamics, depth of anesthesia and the effect of drugs on the human physiology. The inbuilt ventilators have newer modes of ventilation which allow us to ventilate patients with morbid obesity, respiratory diseases, surgery in unusual positions like deep Trendelenburg, avoiding barotrauma. And now in the OT we are following the lung protective ventilation with the low tidal volumes and PEEP, which reduces the post-operative pulmonary complications. The evolution of anesthesia machine from Boyle's machines to modern anesthesia workstations has revolutionized the anesthetic practice. Monitoring is an essential component of anesthetic care. The effects of each and every intervention on the patient by the anesthetist and surgeon are instantaneously picked up by these monitors. Advances in monitoring techniques and better understanding of issues related to pain, stress response, and consciousness have made anesthesia so safe that there is limited exclusion criteria for any surgical intervention nowadays. In olden days, anesthesia was induced and maintained with a single drug like ether. Hence, the complication rates and mortality following anesthesia were high because of the overdose and side effects. The current concept of balanced anesthesia involves using multiple drugs that provide analgesia, hypnosis, muscle relaxation and reflex suppression with minimum side effects and maximum benefits. And we have numerous drugs at our disposal, including inhalation and intravenous anesthetic agents, analgesics and muscle relaxants. The new Millennium saw introduction of many novel active compounds with excellent safety profile. Anesthesia is one specialty which uses inhalation agents in large amounts. The technique of inhalation anesthesia involves delivering gases or vapors through respiratory system to produce anesthesia. The newer agents like sevoflurane and desflurane are delivered precisely through calibrated vaporizers which can be easily titrated. Remifentanil is an ultra short-acting opioid which has recently been launched in India. It's a wonder drug as far as anesthetists are concerned. Patients can be induced to deeper planes of anesthesia within minutes and they can be woken up immediately after surgery. Actually, the property is essential for an ideal anesthetic. Amidst the growing concern about atmospheric pollution, anesthesia practice is gradually adopting intravenous medications. TCI or target control infusion is the technique of administering IV anesthetic drugs aimed to deliver a predictable concentration of the drug in a specific body compartment. The technique uses a computer-controlled infusion pump which delivers the anesthetic drugs based on the patient parameters. In closed-loop TCI, the patient data is collected and analyzed real-time during drug delivery and target concentration is adjusted as a feedback mechanism. Here the patient data is collected, analyzed and drug is delivered by the closed-loop system. While GA keeps the patient sedated, the regional anesthesia allows the surgeon to operate on an awake patient without causing pain or discomfort. Regional anesthesia is the reversible loss of sensation in a specific area of the body when a local anesthetist is injected there. The common regional techniques are spinal, epidural, peripheral nerve blocks, and local infiltrations. The new millennium saw significant advances in the practice of regional anesthesia. The complex central neuraxial blocks like spinal and epidural have given way to simple facial plane blocks, which is easier to administer, and the adverse effects are minimum. The commonly used facial plane blocks are erectus spinae block, transverse abdominis plane block, serratus anterior plane block, PEX 1, 2, and rectus sheath block. Depending upon the site of surgery, we can choose the block. Regional anesthesia can be used alone or in combination with general anesthesia, and it can be continued for postoperative analgesia. The advantages include good analgesia, early mobilization, early recovery, and less postoperative complications. A continuous peripheral nerve block consists of a percutaneously inserted catheter with its tip adjusted to a target nerve through which the local anesthetic is administered. It allows long duration surgeries like a digital reimplantation under nerve blocks alone. The Millennium saw liberal use of ultrasound by the anesthesiologists for their day-to-day practice. It has not only improved safety, but has expanded the frontiers of anesthesiology. It's used widely for regional anesthesia, neuraxial and chronic pain procedures, vascular access, airway assessment, lung ultrasound, gastric ultrasound, focused transthoracic echo, and transesophageal echo. Inability to intubate after administering a muscle relaxant is an anesthetist's nightmare. Ultrasonography of upper airway precisely predicts cases of difficult airway and avoids such incidents. And risk of aspiration and a resultant mortality is high if there is food in the stomach at the time of induction of anesthesia. That's why we ask the patients not to take any food for the 6 hours before anesthesia. But there can be food in the stomach even in the fasting states. Gastric ultrasound precisely quantifies the amount of food in the stomach, which is a vital information for the anesthetist. Ultrasound guided nerve blocks are the most popular ultrasound application by the anesthesiologist. It's a gold standard for regional anesthesia. It improves accuracy of regional anesthesia, especially in difficult anatomical locations. Complications are minimized because of the availability of real-time image of the technique like tip of needle, spread of local anesthetic. Availability of ultrasound in the OT have made our life much easier nowadays. It makes central venous and arterial cannulation easier with minimum complications. It's useful in patients with coagulopathy where multiple punctures are best avoided. Ultrasound guided PICC line insertion is another frequent procedure done in the OT for patients on long-term chemotherapy. High quality arm catheters are available which can be retained for 6 months to 1 year. Today, medical technology enables physicians to treat patients using minimally invasive means outside the operating room. And these specialized procedures take place in remote areas of the hospital like endoscopy suites, cardiac catheterization labs, intervention radiology and pulmonology suites, among others. And often anesthesiologists are called to give anesthesia in these remote locations. For us, the challenges of working in NORA or non-operating room anesthesia are many. Unlike traditional operating rooms, these procedure rooms are built and suited to the procedures, personnel and location specialized to perform unique medical interventions like CT rooms, MRI rooms and all. The challenges include unfamiliarity of the environment. Then often the patients are of extremes of age like very young, newborns to children. Then elderly patients who may not cooperate for the procedure. Then sharing the airway with the pulmonologist for an endobronchial ultrasound or with a gastroenterologist for an endoscopic procedure is often really stressful. As NORA grows, patient safety and quality of anesthesia provided must be emphasized to decrease risk of patients. The recent evidence strongly suggests that many neuro-related complications were preventable through appropriate vigilant monitoring and maintaining the same standard of care as used in the operating room. We have anesthesia machines with full monitors in 5 outside locations. Like other specialties, anesthesia is also in the process of specialization like cardiac anesthesia, neuroanesthesia, pediatric anesthesia. Onco-anesthesia is a recent entrant into that group. Cancer treatment is multidisciplinary and patients receive a combination of surgery, chemotherapy, radiotherapy and palliative care depending on the malignancy and its stage. And anesthesiologist is often a silent companion in cancer care. Majority of patients may need anesthesia for diagnostic or therapeutic management of cancer. The onco-anesthesiologist must be well versed in various modalities of cancer treatment that the patient has received and must be aware of complications, sequelae and adverse effects of each of these modalities. Several studies have suggested that perioperative anesthetic analgesic techniques and drugs may affect postoperative inflammation and immune function. So there is evidence that anesthesia can influence cancer recurrence. Regional anesthesia may increase the expression of several cytokines perioperatively, including interleukin 4, interleukin 10, which may directly or indirectly attenuate surgery-induced pro-inflammatory response. Alternatively, local anesthetics may directly stimulate a natural killer cell activity, which are important in the destruction of tumor cells. And local anesthetics are suggested to have anti-proliferative and cytotoxic effect on cancer cells. This Green OT certification is an internationally recognized certification program which rates the OTs based on the quality and safety of medical facilities available in the OR. It covers the following parameters like preoperative, intraoperative and postoperative care, then infection control inside of OR, electrical safety, fire safety, waste management, and skill of surgical anesthesia team, nurses and supporting staff. Calibrated equipment inside the operation theatre ensure accurate delivery of drugs. Measures to reduce OT pollution with regard to environment and raising the bar of standard of safety in OT. The Green OT certification also ensures that emission of carbon dioxide, infrared rays and radiation are within permissible limits. The idea is to make operation theatres eco-friendly and safe, and patient safety, staff safety and environmental safety are given utmost importance. I am happy to say that Lakeshore Theatre won the platinum grade after the last Green OT inspection. Thank you.
Thanks, Dr. Mallie. The next speaker is Dr. Jaya Susan Jacob, a kaleidoscope of cases.
Good morning, respected Chairperson, fellow speakers, seniors of the dais and my dear friends. Anesthesia at Lakeshore, we never have a dull moment. Every day, we do multiple cases, some which confound us in their complexity, others which give us a deep sense of satisfaction on successful completion, and yet others which make us despondent and invite introspection. I'm going to be presenting a few of these cases. As anesthetists, we like to think of ourselves as the guardians of the patient's airway. So it is a matter of concern when the surgeon wants to share that airway with us. And it's a matter of extreme unease when the surgeon wants to operate exactly on the entrance to the airway, which is the vocal cord. This is one such case. An 11-year-old girl with a 6-month history of change in voice because of a posterior glottic lesion on the left vocal cord. She had underwent an attempted removal by microlaryngeal surgery elsewhere, during which it was reported that she was hemodynamically unstable and had extremely high blood pressure. She was planned for a margin clearance by laser excision. Laser is light amplification by stimulated emission of radiation. So the issues that we had were, one, she was very small. In fact, she was small sized also. For an 11-year-old, she looked more like a 7-year-old. What was the reason for the hypertension? Was it an autonomic dysfunction or was it a light plane of anesthesia last time? Now, laser surgery, there is always a potential for airway fire. Non-availability of pediatric sized laser resistant endotracheal tubes was a concern to us. And again, even if you have no airway in place, in laser surgery, the patient's airway has to be still and immobile. This was the laser surgery being performed on the child. So we had two techniques which we could take. One was the intermittent apneic technique with an endotracheal tube in place, which meant we'd intubate, ventilate, extubate, allow the surgery to go on. When the child desaturates, we re-intubate, ventilate, and the circle goes on and on and on. The second one was to adopt a high flow nasal oxygenation. This device, the HFNC device, was popularized with the COVID pandemic. It was used extensively in the ICUs and now it is being used in theatre as well. This is a Fisher-Paykel equipment. It is capable of delivering flows of 25 to 60 liters per minute, and we can adjust the fraction of inspired oxygen from 0.3 to 0.95. So we opted to go for the second technique, where we pre-oxygenated, anesthetized, initially intubated the child with a 4.5 size tube, ventilated to fill her lungs with oxygen. Then we extubated, put her on HFNO, initially with an FiO2 of 0.9, and we dropped it down to an FiO2 of 0.3. Laser surgery was conducted when the child was apneic. At the first instance of desaturation, the HFNO FiO2 was increased to 0.9. If the child was still desaturating, the surgeon was asked to stop, and we mask ventilated with an FiO2 of 1, which is 100% oxygen. If further desaturating, then we intubated, ventilated, and then extubated and did the same thing over and over again. This time, we were able to provide a total apnea time of 40 minutes for the surgery, which is in 10 episodes of 5 minutes, 3 minutes, 7 minutes, varying times. The total duration of surgery was 3 hours and 15 minutes, and the anesthesia was 3 hours and 30 minutes. This is how the patient's anesthetic chart looked. She was hemodynamically stable throughout the procedure and also did not desaturate significantly. I am pleased to note that she is coming back for follow-up and she made an uneventful recovery. Our second patient was a pregnant lady. Pregnancy is a sacrosanct time for all families concerned, and any disease complicating pregnancy is a matter of concern for the families and for the doctors. More so if it is cancer complicating pregnancy. The incidence of cancer is now about 1 in 1,000 pregnant women, and apparently it is increasing as well. And there are moral and ethical issues involved here. Do we look after the mother? Do we concern ourselves with the child who's going to be born? Do we allow the pregnancy to continue? So our patient was a 27-year-old primary gravida who at 28 weeks of pregnancy conceived out of IVF, presented with an ulcer on the lateral border of the tongue. It was biopsied and the diagnosis was a moderately differentiated squamous cell carcinoma. The surgery that was planned was a wide local excision with neck dissection and a radial artery free flap reconstruction. So our issues here, patient was in the early 3rd trimester. We had to anticipate a major surgery, prolonged major surgery. So we had to anticipate and prevent major hemodynamic shifts to allow for the pregnancy to continue, and invasive lines would be required. For maternal well-being, we had to ensure that there was no hypotension throughout the perioperative period, which meant that she had to have a left uterine displacement to prevent aortocaval compression throughout the perioperative period, which is pre-op, intra-op, and post-op. And she also had DVT prophylaxis, which was by intermittent compression stockings. For monitoring of the fetal well-being, FHR monitoring was done continuously by cardio-topography. And to allow for continuation of pregnancy, her uterine contractions were also monitored continuously intra-op. She was administered tocolytics, which is injection duodenum pre-op, and duodenal and progesterone post-op to prevent preterm labor. The anesthetic technique was also tailored likewise, where we opted for inhalational anesthesia because volatile agents are also muscle relaxants, smooth muscle relaxants. The surgery lasted for about 8 hours. It was mostly uneventful. The fetal heart rate that was monitored throughout was always over 125. Subsequently, she has received 2 cycles of chemotherapy, and at 36 weeks, she had an elective cesarean section and she delivered a healthy baby girl. And she is now on adjuvant radiotherapy. So this is an example of a multidisciplinary approach where multiple specialties came together to take care of this complicated pregnancy, and successfully too. The last case that I want to present is the health challenge of the 21st century, a leading cause of death and disability, which affects more than 250 million people worldwide. Initially, it was considered a problem of the affluent society only, but now it is spreading rapidly in low and middle income countries, and India is a major contributor. Obesity. I must say that this is by no means the heaviest patient that we have done. Dr. Padmakumar has done much more bigger patients, about more than 180 kg patients. This patient has been highlighted here for a specific purpose, which I will come to later. This patient weighed 154 kg, which is a BMI of 54.5. He had a history of hypertension and obstructive sleep apnea. He had sustained trauma to the right hip after a road traffic accident, resulting in a highly comminuted fracture of the acetabulum. He underwent fixation of the acetabulum elsewhere, and he continued to have recurrent dislocation. He was ambulant with the help of a walker. He was planned for a 2-stage hip arthroplasty. Initially, he had an implant removal and stimulant insertion under general anesthesia, during which there was major blood loss. He had massive transfusions and about 5 units of blood given. And 3 weeks later, he was planned for a total hip replacement, which was done under general anesthesia with regional block. So our issues with this patient was morbid obesity, difficult vascular access, and the possibility of, again, massive transfusion requirement once again. To give you some idea of how really obese this patient was, this is the lateral aspect of his thigh. The first picture is at the initial part of surgery, and the last is as they were closing. As you can see, there's a lot of tissue. So what were we going to do about post-op analgesia as well? Now, continuous epidural analgesia, which is one of the more common options that we choose, was not feasible in this patient for 2 reasons. Number one, we could not position him. Since he had had a surgery just 3 weeks back, positioning him to put in an epidural was extremely difficult, and we did not do that. And secondly, putting an epidural right in the beginning of surgery may have caused some hypotension intra-op as well, when we were already anticipating that there would be massive blood loss. So we decided to go with fascia iliaca block and a pen block, which is a pericapsular nerve group block, as well as rescue analgesics. Both these nerve group blocks could not have been possible without the use of the intraoperative ultrasound, which is a sonocyte that we use in the theatre. And also, they would not have been possible without the use of an extra long nerve block needle. We had to use a 150 millimeter, that is a 15 centimeter needle for this purpose. Fascia iliaca block is an infrainguinal block, which covers most of the thigh and the medial aspect of the leg. And the pen block is a suprainguinal block, which covers a few of the nerve fibers which go to the upper part of the hip joint. The patient had a fairly uneventful intraoperative course. Of course, he did have some hypotension. He needed 2 units of blood. He was shifted to the ICU, and he remained in hospital for about another 2 to 3 weeks before he was discharged home. So to conclude, an operation represents premeditated trauma. One size does not fit all. So different folks need different brushes applying different strokes. So we cannot always go by a protocolized approach, and we need to individualize when patients are concerned. No man is an island. In all these cases, especially complicated cases, success would not have been possible without the combined effort of different specialty doctors, nurses, OT and anesthesia technicians, therapists and nutritionists. My sincere thanks to all of them, and thank you all for a patient hearing.
Thank you, Dr. Jaya. The next one is given to one of our consultants, whose experience may be far less than the remaining speakers seated on this platform. They are the people of the future, and it is for them to initiate, during their short span of experience, what progresses they have to make to keep themselves up for the next 50 years. Anju, you can go ahead. Thank you.
Good morning, all of you. I will be dealing with marvels of anesthesia, a sneak peek into the future. That is the future of anesthesia. So artificial intelligence has taken over the modern medicine, and even in anesthesia it has taken over. So let me tell you a few things about artificial intelligence before moving on to the anesthesia proper. Artificial intelligence is the capability of computers to respond in a manner resembling human intelligence. So what we're trying to do is to try to ape human intelligence in computers. That is to reason, learn and make decisions, solve complex problems, perform high-level computations with increased accuracy. John McCarthy in 1956 described artificial intelligence first. Some of the terminologies in AI, which I'll be dealing in my further slides. One is ML or machine learning. It is a subset of AI that provides a system to automatically learn and improve the experience without being explicitly programmed. That is, the computer is trying to learn from the data given. It's not just the program, but try to learn over the experience. The ML classified as supervised, unsupervised, and reinforcement learning. The next subset of AI is the deep learning or DL, and the DNN, that is the deep neural network. It is the subset of machine learning where artificial neural networks and algorithms inspired by human brain learn from large volume of data. Now the evolution of AI, many of these logos that I have depicted there, the Amazon Alexa, Siri, ChatGPT, Google Bard, and Sophia Robo. The ANI is the artificial narrow intelligence. The machine has narrow defined role or task. Example, Siri, Alexa, and the chatbots like ChatGPT. AGI is the artificial general intelligence where the machine thinks just like humans. That is what's currently developing. We have the Robo Sophia, who can speak more or less like humans, and even she was given citizenship in Saudi Arabia. She is the first non-human citizen of Saudi. And ASI is artificial superintelligence, where the machine surpasses human thinking. Currently only in science fiction movies, in Hollywood movies, but we are expecting in reality in the coming age. So these computers are more intelligent than humans. So AI in anesthesiology. The American Society of Anesthesiology has defined certain themes of application of AI in anesthesiology: the depth of anesthesia monitoring, control of anesthesia, event and risk prediction, ultrasound guidance, pain management, and operating room logistics. In the event and risk prediction, for an example, an AI algorithm for hypertension prediction index has been devised as per arterial waveform analysis. A real-time prediction of upcoming hypotensive events at least 15 minutes ahead of the real event. So it will prompt the anesthesiologist to act earlier to manage impending hypertension. The use of ML-derived early warning system compared with standard care resulted in less intraoperative hypertension. What are the limitations of AI? It needs high quality data. The data that you feed into the computer should not be poor data, because that will affect the healthcare. As the AI algorithms are trained based on these data with ML and DL for progressive learning. The patient's safety may be jeopardized by incorrect AI algorithms. Data privacy may be at stake. AI lack empathy and human judgment. And there are a lot of legal and ethical issues. Because if something happens to the patient, who will take the responsibility? We can't say the robot or the AI did it. So there should be someone above AI who can take responsibility for what if something goes wrong. Now first let me tell something about the future we expect in our PSC clinic. So the future PSC clinics, which is already in the current scenario, but it will be more common in future. We'll add on the Google Translate, AI-assisted pre-op anesthesia risk prediction, AI and difficult airway assessment, and robots in PSC clinics. Language barrier in PSC rooms in the era of medical tourism. We have a lot of patients from different states of India as well as abroad, and we struggle with them. We try to do actions and try to speak Hindi or English, but they don't know half what we are speaking, we don't understand what they are speaking. So the Google Translate in PSC is used for real-time translation of medical history. In Feb 2023, Google announced updates on Translate app. Google is using AI to add more contextual information to translations. It helps us to use words that have multiple meanings according to the context. Future, there will be an AI interface in the PSC clinics. Now, what about predictive preoperative anesthetic risk? The data of the patient's medical and surgical history, pre-op lab investigation and imaging results are all fed, and the AI will predict the pre-op anesthetic risk using algorithms via the ML and the DL, that is machine learning and deep learning. Anesthesiologists in the future may rely on AI's ability to quickly and accurately sift through the large stores of medical data, uncover correlations and patterns that are imperceptible to human cognition. Some patients, they come with big case sheets or a lot of history, and it takes a lot of time. So you just feed the data to the AI and it will sift through the stores of medical data and give us what is finally required for the particular surgery. The performance and outcome perioperatively is further used for deep learning for the future use. AI-assisted assessment of difficult airway. Now a difficult airway for intubation, it is a great nightmare if something goes wrong. So what if we use AI also in that? So AI advanced 3D facial recognition technology uses ML algorithms as an aid to distinguish a difficult airway. Hyundai et al. Made a fully automatic system to collect the patient's facial photos with mouth open, tongue protruded, head extended as well as laterally rotated, and processing of photos through ML. Patients' existing head and neck imaging like X-ray, ultrasound, CT and MRI will contribute to the assessment, but if it's not present, we will use the photos. Now, how about robots in PSC? So there was an experiment conducted where anesthesia service robots were used. Now this is an example of a Zenbo robo, the service robo produced by ASUS. They ask questions based on data collected from different human anesthesiologists. They will feed the data from anesthesia, what all the questions have to be asked. And the Zenbo robo will generate a medical record in PSC. In the pilot study, the robot didn't use any purposeful follow-up questions. For example, if you ask the patient, do you have diabetes? And patient say yes. Now what is the follow-up question? How long you had? What are the medications you are taking? So the skip logic design was added where the robot jumps to the related follow-up questions for each medical history. Result, time saved for the anesthesiologist. Patient satisfaction, yes, because patients prefer cute robots than boring anesthesiologists. And we have PSC chatbots. The AI chatbot app can be installed in mobile phones of patients. The PSC can be taken up by the conversational AI chatbots. It will speak to us even from home, even before coming to hospital. And it acts as an intelligent virtual assistant. Now GA or general anesthesia from present to future. Now CLADS or the closed loop anesthesia delivery system is already present. And one is the MEC-SLEEPy, which is the world's first automated anesthesia system. It had 3 separate parameters displayed on an integrated monitor, which assess the depth of hypnosis via EEG analysis or BIS monitoring, pain via the pain score called Analgoscope, and muscle relaxation via the neuromuscular monitors. The drugs were given auto, using the conventional infusion pumps, controlled by a laptop on which MexLP was installed, and it analyzed the biological information and constantly adapted to its own behavior, monitoring and recognized any malfunction if present. I control RP. RP stands for remifentanil and propofol. It uses bispectral index, SpO2, heart rate, respiratory rate and BP monitoring. Drug delivery is altered automatically based on these parameters. Now, new anesthesia workstations, target control ventilation with self-adjustments for set target of end-tidal carbon dioxide and minute ventilation. MAC, or the minimum alveolar concentration of inhalation anesthetics, adjusted as per set target for all age groups, that's pediatric to geriatric. Now we have currently coming into our market new highly advanced anesthesia workstations which have high flow nasal cannula integrated that can extend the safe apneic oxygenation, automatic control anesthesia system that can automatically adjust fresh gas and vaporizer output to quickly achieve the preset target end-tidal agent and inspiratory oxygen concentration, and also the lung recruitment tool which is helpful in patients with lung pathologies, obese patients, etc. And these have precise electronic vaporizers. Xenon in anesthesia. Xenon is an inert gas which can be used as an inhalation anesthetic. It has low blood gas partition coefficient, permits rapid onset and offset of action, good analgesic properties, cardio-stable, environment friendly. But what's the problem? Xenon is available only in trace elements in our atmosphere, and it's a lot of cost is involved in its processing. Now in the future we shall have newer workstations like Felix dual anesthesia workstation and Wiener Xenon workstations, and they have the technology to recycle the Xenon and reuse it and make it cost effective in the future. Now, robotic innovation into the OT in perspective to the anesthesia. Now, mask ventilation by a robo. Okay. The novel anesthesia airway management robo for robo-assisted non-invasive positive pressure mask ventilation. It was published by Dr. Ma et al. From China. Ma designed a robot equipped with 2 snake arms and a mask fastening mechanism to facilitate anesthesia. The 2 snake arms were designed to fit a patient's jaw, and the mask fastening mechanism was used to fasten and hold the mask onto the face using a joystick. So the anesthesiologist is not near the patient, but he uses a joystick to adjust. Proposed a method to perform non-invasive positive pressure mask ventilation via robotic system. Now the Kempler intubation system and Da Vinci for fiber optic bronchoscopic intubation. This has already been successfully done by Dr. Hemmeling in McGill University in 2012. But it does not come into common practice in or common OT because the anesthesiologists have to use joystick to intubate the patient, and I think at the current scenario that the anesthesiologists do it faster than the robo. So, but we have to make the robos faster than us. That is what we expect in the future. And Da Vinci surgical system has anesthesia robots for fiber optic and bronchial intubation. Next is the Magellan robotic system and Da Vinci robot arms for nerve blocks. So nerve blocks are very important in our anesthetic armamentarium. So the ability of the nerve blocks to grasp, manipulate and appropriately connect the equipment involved in a peripheral nerve block was tested. The Da Vinci was able to grasp and manipulate the block needle. It could connect a Luer-Lock syringe to the needle's injection port and also give the anesthetic drug. So definitely it can be used in future for block needle placement and perineural catheter placement. And we have a decision support robos. So when the anesthesiologists are perplexed and you want an input from somebody else, we have robos for that, decision support robos. So it can recognize a crucial clinical situation that requires human intervention, and then allowed by the attending clinician, it will also administer drug. And these are called the cognitive robos, which follow algorithms and increase the patient safety. Next, about the next generation airway gadgets. We have heard about video laryngoscope. This is a video laryngeal mask. That is an LMA or IGEL with a camera attached to it. The VLMA includes a disposable, because many a times when you introduce an IGEL or an LMA, at times it will become mal-positioned. So it is good if you have a camera at the end. So the VLMA includes a disposable second generation SAD, that is second generation supraglottic airway, with a silicone cuff, anatomically curved tube, and reusable video scope and monitoring system. During intubation, these devices guarantee continuous oxygenation, allow visual inspection of the supraglottic area and distal to the cuff. Example is video laryngeal mask and safe LM. Then another one is the SARCO VLM, that is the novel LMA with integrated camera at its tip. Other one was the LMA is attached to the video laryngoscope, and then after the correct positioning of the LMA, we will detach the video laryngoscope. Second one is LMA with integrated camera. Advantages are easy insertion under direct vision, reduced airway damage, capacity to pass an endotracheal tube through the SAD, and recording. Also, it can also record the events. Y-scopes. Many a times you want simple techniques of intubation for difficult airways. So Y-scope is a feature which features a closed circular tube with a bevel end. It is transparent and illuminated. It allows direct glottic visualization and facilitates endotracheal intubation through a bougie. Next is the IRRS, that is infrared red intubation system. It was first described by Christensen et al. Now, it's a very good gadget that we have a small infralight source. It will be attached over the neck. It has a wavelength of 730 to 100 nanometer. It's placed over the anterior cervical surface over the cricothyroid membrane. The device will emit infrared light through the skin of the patient to the subglottic space, and the VL scope is placed in the airway. The video scope will display a bright light emerging from the glottis, guiding the path. The IRRIS technique has also been used in combination in flexible bronchoscopy also. During fiber optic bronchoscopy, even though we are directly visualizing it, sometimes it's difficult to see the glottic opening. If we use an infrared light source, we'll be able to see it more properly. Now, Viva site endotracheal tube. These are endotracheal tubes with camera attached to the endotracheal tube. So currently we use video laryngoscope and we introduce the tube blindly into the trachea. After crossing the glottis, we don't know what happens to the tube. So here we have the endotracheal tubes with camera attached to it, so that after the glottis, through the trachea, till the final position, we can see what's happening. It is embodied with 2 light-emitting diodes and a miniature integrated high-resolution video camera at its tip. The integrated camera provides visual assurance during intubation. It enables continuous intraoperative tube evaluation. That is, in intraop, if something happens, we know what is at its tip. It helps in bronchial block curve placement for 1 lung ventilation, and the device is available in size of 7 and 8. Now, the VivaSight WMN tube is also available with tracheal and bronchial cuffs. Now, next is how small can you create? That's the era of nanoparticles. So, nanotechnology and nanorobots have come into medical practice. It was first described by Nobel laureate Richard Feynman in 1951. Nanoparticles are 1 to 700 700 nanometers in size. Now, medical nanorobots was first described by Robert A. Priestas. So, these nanorobots, there's very small particles, okay? So, once injected, the nanorobots would freely float inside the body, detecting and attaching to very specific receptors and perform focused tasks. It has a task, focused. Only to those receptors it will go. The nanotechnology with the AI has extraordinary capacity to monitor the human body at molecular level. The nanocarrier-based drug delivery system can target specific cells or tissues to delay the drug metabolism and clearance and improve the drug's total bioavailability. The submicron size particle permits them to pass through the endothelial fenestrate and penetrate tissues at the capillary level. Now, nanorobots in anesthesia. We can use nanorobots and it will attach to specific GABA receptors that produce loss of consciousness and amnesia. At the neuromuscular junction, provide full muscle relaxation, activation of specific opioid receptors, whether mu1 or kappa, whatever. The specific opioid receptors cause profound analgesia. And an antidote to bupivacaine overdose by formation of pi-pi complex and nanolidogel or lignocaine is available. The desirable characteristics of a nanorobo is an optimal size of 0.5 to 3 micrometer to enable passage to the capillaries, non-agglutinable with the blood cells, and very specific receptor recognition. Now, nanotechnology in blood component replacement, we have the vasculoid, respirocytes and clotocytes. Vasculoid is complex, multi-segmented nanotech medical robo system capable of all transport functions of the blood. So there is circulation of the respiratory gases, glucose, hormones, cytokines, waste products. So the vasculoid conforms to the shape of the blood vessels and serve as a complete replacement of natural blood. So, and respirocytes, these are nanostructures which transport oxygen in human body similar to erythrocytes. The proposed structure consists of 3 chambers. One would store the oxygen, the other carbon dioxide, and third would act as a buoyancy chamber, making the structure floatable in blood. Next is the clotocytes or artificial platelets. They halt bleeding 100 to 1,000 times faster than natural platelets. It is specially programmed, motile clotocytes detects internal bleeding and spontaneously go and seal the site. Advantages of nanotechnology. Nanorobots are biocompatible entities. They are useful in both general as well as regional anesthesia. They are highly specific and target oriented, lesser drug usage, less drug wastage, and limited side effects. As they bind the terminal receptors, there shall be no peaks and troughs, and it can improve the drug solubility, change the drug distribution, adjust the release rate to obtain the sustained release and control release profiles. Disadvantage is high cost and complicated fabrication. Next is genomic anesthesia or precision medicine. Precision medicine is a new strategy which is accepted in many fields of medicine. Treating and preventing diseases that considers a person's unique genetic makeup as well as their environment and lifestyle choice.
Sorry to disturb you. 2 more minutes.
Okay, sir. Pharmacogenomics, the reaction of our body to anesthetic is greatly influenced by these genes. Now, reimagining regional anesthesia, what's in store for future? The novel approach is ultrasound-guided needle tip tracking. So many a times it is difficult to see the needle tip. So we will have a green circle which will show the needle tips. AI and ultrasound-guided regional anesthesia, this technique uses despeckling filters and increase the contrast of the region of interest and reduce the background speckle. Nerve blocks is an AI-based image interpretation connected to the video output of any existing ultrasound device. It will auto-detect key anatomical landmarks for specific nerve block. Next is the Saphira or the safer injection for regional anesthesia. We don't have to have any assistant for injection of the local anesthetic. The consultant performing the regional anesthesia will have a button in the hand or a foot pedal to inject the drug. Now, future of anesthesia and obstetrics, US guided, ultrasound guided neuroscial techniques with AI assistance, with identification of the midline in obese patients, improved access to intrathecal and epidural space, and automatic spine level identification, which will identify the vertebral landmarks in real time. Augmented reality is an immersive virtual reality in labor analgesia and in pediatrics. It's an emerging non-pharmacological technology which involves distraction of the parturian and creation of virtual environment with cognitive capacity to distract the pain. Teleguidance for intubation, teleglass or Google Glass technology to assist endotracheal intubation, especially for novice people. And a focus of point of care ultrasound is currently coming into practice. Many aspects like airway ultrasound for assessment of neck before intubation, residual gastric volume in the case of risk of aspiration, and identify the correct endotracheal placement after intubation. Future AI assisted focus with data analysis through ML. Telemedicine and smartphone anesthesia, digital interface platforms that extend the reach of anesthesiologists well beyond the perimeter of an operating room. AIMS and SAM. AIMS is AI-supported anesthesia information management system, which will help in automated record keeping, monitoring details and vitals of all the patients in the hospital. And SAM or Smart Anesthesia Manager, an AI system that works in conjunction with AIMS, which is recommended for suggestion for anesthesia management using ML. And anesthesia education in the future, authentic lifestyle simulation scenarios, not just in conference, even in medical practice, the AI, the anesthesia residents will have more frequent simulations, individualized learning experience, data-driven feedback, and which will help in improving the decision-making skills. And augmented reality for training anesthesia residents is also in the pipeline. Thank you.
The floor is open for questions to the speakers. This is a common thing that we see with all clinical meetings. The specialties have a very high grade of knowledge which they do not communicate to the public. Only 20%, I'm sure a few people sitting here will know. The remaining 80 is the handwork of that specialty department. And that has been happening over the many years that we have conducted this continuing medical education or our meetings at Lakeshore. I must thank my managing director, Mr. K Abdulla, for giving us an opportunity to work towards the modern era of anesthesia. People, juniors sitting here, don't have to get worried. Although the sneak peek into the future by Anju kept on talking about robots, but our medical director had already bought us a robot to make you aware that robots cannot take over human beings. I have 23 specialties at Lakeshore Hospital coming to the operating theatres over a week. And out of that, Gynae Smita is sitting here. She has got 3 units. Plastic has got 2 units. Orthopedics has 4 units. And juggling with 23 departments in 11 operating theatres. There is a book entitled, What They Don't Teach You in Harvard. See, nobody can teach you how to juggle with these 23 departments in 11 OTs. Quite a few of them fly off, getting angry with the anesthesiologist or the nursing profession. But we have always followed a principle to keep every surgeon happy when it starts in the morning because he's doing a very dangerous surgery on a human being. So we do not enter into any conflict with surgeons in the morning of surgery. We keep them happy and everything goes on very smooth. But let me tell you, the HR department of this hospital cannot have the far sight of the anesthesiology department of Lakeshore. Because here, we have to manage situational brilliance. Because 23 people are phoning us. We have got about 5 departments outside the operating theatre wanting us. And at the same time, we have to make sure how we can use the resource utilization that we have amicably and for the patients that really require them, just not at the beckon of a surgeon. At the same time, we maintain 100% human relationship with our surgeons. And I'm sure, till today, I've always had a brilliant report of my department from every surgeon at Lakeshore Hospital. And sitting on the stage, I'm happy. And I continue to thank my managing director because that sneak peek into the future is going to cost a lot of money. Thank you, one and all, and we'll disperse for breakfast.